Welcome to the Deep Dive. We're here to take complex sources and really boil them down to the essentials you need.
Exactly, getting straight to the key information.
And today, we're tackling a really common condition, one that's definitely high yield for medical exams, like the MSRA, chronic plaque psoriasis.
Absolutely. It's much more than just a skin issue, as we'll see. Understanding it properly is, well, fundamental. For exams, yes, but also just for good clinical practice.
Couldn't agree more. So we've got comprehensive notes here covering the key aspects. Our mission, to break down chronic plaque psoriasis definition, causes, features, management, extracting those crucial facts for revision.
Let's do it.
Okay, let's start right at the beginning. The definition. When we say chronic plaque psoriasis, what exactly is it?
So at its core, it's a very common chronic autoimmune disorder. Primarily affects the skin.
Autoimmune.
Yeah.
And the key feature is these plaques.
That's right. They're basically well-defined areas of skin that are raised, inflamed, red, really, and covered with quite thick, silvery white scales.
Raised, red, scaly.
Got it. Is this the main type of psoriasis people get?
Yeah, by far. It accounts for about 80% of all psoriasis cases. You might sometimes hear it called psoriasis vulgaris, or the chronic stationary type, same thing.
Okay, psoriasis vulgaris. And you mentioned autoimmune. What's the immune system actually doing to the skin here?
Well, it's essentially a case of mistaken identity. The immune system gets confused and starts attacking healthy skin cells.
Right.
It's a chronic inflammatory process driven specifically by immune cells called T cells. These T cells become activated inappropriately.
And they cause the inflammation.
They do, yeah. They release signals that tell the main skin cells, the keratinocytes, to grow much, much faster than they normally would.
So it's like the skin cell production line is massively sped up.
That's a really good way to put it. Instead of shedding normally over weeks, the cells pile up in just a few days. That buildup plus the inflammation, that's what creates the plaque.
Okay, that makes sense. Which leads us neatly into the etiology, the why. Do we know what actually kicks this whole process off? That's the big question, isn't it? And the simple answer is we don't know one single exact cause. It's complex.
We're not just one thing then, like a specific bug or something.
No, not like that. It seems to be an interplay. There's definitely a strong genetic component. It often runs in families.
The genetic predisposition.
Exactly. But genes aren't the whole story. You need that underlying genetic susceptibility, plus the immune system dysfunction we talked about, and usually some kind of environmental trigger.
Right, the trigger factors.
Yeah.
You could have the genes, but need something to actually set it off.
Precisely. Or something to cause a flare-up if you already have it.
Okay, talking about triggers. What things make someone more likely to get psoriasis or have a flare? What are the key risk factors?
Yeah, there's a fairly well-established list. Family history is a big one, as we just said.
Right.
Stress is a really common trigger. Many patients report flares during stressful periods.
I bet. What else?
Infections, particularly streptococcal infections, like a strep throat. That's a classic trigger for guttate psoriasis, but it can influence plaque psoriasis too.
Interesting, this strep throat link.
Also, obesity is a definite risk factor. And smoking. Both tend to be linked with more severe disease as well.
Okay, obesity and smoking. Any medications we should watch out for?
Yes. Definitely some key ones to remember for revision. Beta blockers,
Right.
for heart conditions and blood pressure. And lithium, which is used in psychiatry. Those are probably the two most cited ones.
Beta blockers and lithium. Got it. Okay, now this next bit feels really crucial for thinking holistically. Associated diseases. Psoriasis isn't always just about the skin, is it?
Not at all. And this is so important. It often comes with other conditions. The most well-known association is psoriatic arthritis.
Right, the joint involvement. How common is that?
Figures vary a bit in studies, but it's estimated somewhere between, say, 7% and maybe up to 40% of people with psoriasis develop it.
Wow, that's a pretty wide range, but even at the lower end, it's significant.
It really is. It causes joint pain, stiffness, swelling, and without treatment, it can cause lasting damage.
Okay, so psoriatic arthritis is key. What else is linked?
There's a link with inflammatory bowel disease, so
Yeah.
Crohn's disease and ulcerative colitis.
Right.
And a very strong link with metabolic syndrome.
Ah, yes, the cluster of issues.
Yeah.
Obesity, high blood pressure.
Exactly. Central obesity, hypertension, insulin resistance, which can lead to type 2 diabetes and dyslipidemia, so abnormal cholesterol levels.
Which all points towards.
Increased cardiovascular risk. People with psoriasis, especially severe psoriasis, have a higher risk of heart attacks, strokes, cardiovascular disease in general.
So it's not just skin deep at all.
Definitely not. There are also slightly increased risks of lymphoma and non-melanoma skin cancer. You really have to think systemically.
Okay, let's quickly revisit the pathophysiology. Just nail down that core mechanism again.
Sure. So back to those T cells. They get wrongly activated. They release inflammatory chemicals, cytokines. These cytokines then tell the skin cells, the keratinocytes, to multiply way too fast.
In days instead of weeks.
Right, and they don't mature properly either. So they pile up along with immune cells, creating that thick, inflamed, scaly plaque. Immune signals driving rapid, faulty skin growth. That's the essence.
Got it. Okay, clinical challenge time, differential diagnoses. Someone comes in with a red scaly patch.
Yeah.
What else could it be? This list is important, right?
Crucial for exams, yeah.
Okay.
Lots of things can mimic psoriasis. You've got to consider Bowen's disease. That's a precancerous skin lesion.
Okay.
And, as mentioned, cutaneous T-cell lymphoma. Especially if a rash isn't responding as expected or looks a bit odd, keep that in the back of your mind.
Right. Important not to miss that. What else?
Simple drug eruptions, reactions to meds. Lichen planus can sometimes look similar. Discoid lupus.
Okay.
Various types of dermatitis or eczema, though often the borders are less sharp in eczema. Pityriasis rosea usually has that herald patch and fir tree pattern.
Right.
Seborrheic dermatitis, often greasier scales, scalp, face, Tannicorporous fungal ringworm. You'd look for central clearing, maybe.
Fungal. Okay. Anything less common?
Well, secondary syphilis can cause rashes that look a bit like psoriasis sometimes, and even a superficial basal cell carcinoma, a type of skin cancer, might present as a persistent scaly patch. Oh, and eczema again, of course.
That is a long list.
Yeah.
How do you sort through that?
It comes back to knowing the typical features of psoriasis really well. The distribution elbows, knees, scalp, the look of the plaques, those sharp borders, the silvery scale, the specific signs like auspices, those are your big clues.
Yeah.
If it doesn't quite fit that classic picture, then you start working through this differential list.
Makes sense. Let's get some numbers. Epidemiology. How common is it?
Pretty common. Affects around 2% of the UK population.
2%. And chronic plaque is the main type.
Yep, the vast majority. Usually starts in early adulthood, typically before 35. Less common in kids.
And demographic?
Affects men and women equally, but it is more common in white individuals. And remember, that joint disease figure, around 13.8% or so, develop psoriatic arthritis.
Okay, that context is useful. Now, the really key bit for recognition, clinical features. Describe that classic plaque again.
Okay, so you're looking for those clearly defined, raised, red, erythematous plaques, and they're topped with silvery white scales. That's the hallmark.
And the classic spots to find them.
Extensors are classic, so elbows and knees, very common. Also the scalp, lower back trunk, and buttocks, often symmetrical.
Sharp borders, you said?
Very sharp demarcation from normal skin. That's quite characteristic. Plaques can be small, maybe 1 centimeter, or merge into really large areas covering, significant parts of the body.
Are there those specific signs again? Auspice's sign.
Yes, Auspice's sign. If you carefully remove a scale, you see pinpoint bleeding spots.
Okay, and the other one? Koebner.
Koebner's reaction, or phenomenon. That's where new psoriasis lesions appear in areas where the skin has been injured, a scratch, a surgical scar, even sunburn.
So trauma triggers new lesions. Interesting. Anything else about the appearance? Fissuring?
Yeah, plaques can crack or fissure, especially over joints or on the palms and soles. That can be really painful.
And color variations.
Usually bright red or pink. Sometimes a slightly bluish or violaceous hue, maybe in darker skin. In kids, remember, the plaques might be thinner, less scaly, and often pop up on the face.
Right. Facial involvement, more common in children. And the nails. What are the key nail changes?
Nail changes are super common. Look for pitting tiny dents on the nail surface, onycholysis, where the nail lifts off the nail bed,
Okay.
and subungual hyperkeratosis, that's thickening and scaling under the nail, making it look crumbly or lifted. These can be clues to psoriatic arthritis, too.
And how do we grade how bad it is? Severity.
It's usually based on body surface area, or BSA. Less than 5% is generally mild, 5–10% moderate, over 10% is severe. But it's not just about the area. You have to factor in the plaque thickness, the scaling, and crucially, the impact on the patient's quality of life. How much does it itch? Does it affect sleep, work, social life? That's just as important as the BSA. There are formal scores like PSI, but BSA and quality of life impact are the main things.
That paints a very clear picture. So with these features, investigations. Mostly clinical diagnosis.
Absolutely. For typical plaque psoriasis presenting in the classic way, diagnosis is clinical, based on seeing those characteristic lesions in the typical spots.
So no routine blood tests or biopsies needed.
Not usually, no. Biopsy is really for when it looks unusual, or you're seriously considering something else from that differential list, like the T-cell lymphoma or lupus. Dermoscopy might occasionally help, but it's not standard. Look and listen, that's usually enough for diagnosis.
Okay, great. Diagnosis sorted. Now, the big one, management. How do we actually treat chronic plaque psoriasis? This is key for revision.
It really is, and it's usually a stepwise approach. Start simple, escalate if needed. The goal is control, not cure, remember?
Right. So what's step one, usually for milder cases?
Topicals are the mainstay. First line often involves potent topical corticosteroids to quickly reduce inflammation and scale. Often used alongside vitamin D analogs, like calcipotriol. They help slow down the skin cell production.
Steroids and vitamin D analogs.
Makes sense.
And emollients, really important. Regular use helps hydrate the skin, reduce scaling, ease itching, absolutely fundamental.
Any other topicals?
Yeah, there are others. Tar preparations are old but still used. Tazarotene, a topical retinoid, can work but can irritate. Dithronol is effective for thick plaques, often used as short contact therapy because it stains.
Okay. And different areas need different approaches.
Definitely. You need milder steroids for the face and skin folds, as the skin's thinner there. Scalp often needs special shampoos or lotions.
Got it. What if topicals aren't cutting it or it's more widespread?
Then the next step up is usually phototherapy, controlled exposure to UV light in a hospital setting.
UV light therapy. Usually narrowband UVB is the first choice. PUVA, which combines UVA light with a drug called psoralen, is another option, perhaps for more resistant cases.
And if it's severe or phototherapy doesn't work or isn't suitable.
Then we move to systemic treatments. These are tablets or injections that work throughout the body.
Okay, what are the main systemic options?
Well, there's methotrexate, an immunosuppressant, cyclosporin, another potent immunosuppressant, often for rapid control but usually shorter term, acitretin, an oral retinoid, and dimethylfumarate, or Skilarence, is a newer tablet option. These all need careful monitoring for side effects.
Right, monitoring is key with systemics. And then the top tier, biologics.
Exactly. Biologic therapies are generally reserved for severe resistant psoriasis that significantly impacts quality of life and hasn't responded to other systemics or phototherapy.
These are the targeted therapies.
Yes, they target specific immune molecules involved in psoriasis, like TNF-α or interleukins 17 and 23. Things like etanercept, adalimumab, ustekinumab. There are quite a few now. Very effective, but they come with specific risks and monitoring needs, and they're expensive.
Okay, quite a ladder of options there. What about the general care aspects?
Hugely important. Patient education is key, helping them understand it's chronic, how treatments work, managing flares, addressing the psychological impact. Is vital anxiety, depression, or common?
Yeah, that must be tough.
Absolutely. And don't forget screening assess cardiovascular risk factors, especially in severe disease, and ask about joint symptoms for psoriatic arthritis. Treatment decisions should always be shared, factoring in the patient's life and preferences. Regular follow-up is essential.
When should a GP refer to dermatology?
Referrals needed if you're unsure about the diagnosis, if it's severe or extensive, if it's not responding to initial treatments, if it's having a major impact on their well-being, or for tricky nail psoriasis.
Okay, clear guidelines. So, manage symptoms, improve quality of life. That's the aim.
That's the realistic goal, yes. Finding the right balance of treatment for each individual.
What about the long term? The prognosis, what's the usual journey like?
It's typically chronic, lifelong, and unpredictable. People tend to have flares and remissions. The pattern varies hugely.
Any clues it might be a tougher course?
Generally, starting younger and having a strong family history sometimes points towards more persistent or severe disease later on. And a really crucial point on prognosis, or rather risk, systemic corticosteroids are generally avoided. Abrupt withdrawal can trigger really severe, potentially life-threatening pustular or erythrodermic flares.
That's a vital warning. Avoid systemic steroids. Is psoriasis itself fatal?
Directly from the skin disease. Extremely rare. The risks come more from potential long-term treatment side effects like liver issues with methotrexate, kidney with cyclosporin, maybe skin cancer risk with lots of phototherapy, and of course that increased cardiovascular risk we keep mentioning. Managing that and monitoring treatments is key for long-term health.
Right, which leads perfectly into the potential complications. What are the main ones to summarize?
Number one is psoriatic arthritis. Joint inflammation, pain, potential damage.
We've definitely established that one.
Good. Then there's the major psychological impact: anxiety, depression, low self-esteem, social isolation.
Understandable, given the visibility.
Very much so. It leads to impaired quality of life generally. Then the systemic links again: increased risk of cardiovascular disease and metabolic syndrome.
Okay.
And finally, complications from treatment itself, like those severe rebound flares if steroids are misused.
So it really reinforces that psoriasis is way more than skin deep. Immune system, joints, heart, mental health. It's all connected.
Absolutely. You have to see the whole picture.
Which leads us to a final thought for you to ponder. Given everything we've discussed, the chronic, unpredictable nature, the links to systemic health like heart disease and arthritis, the psychological burden, and the range of treatments from simple creams to complex biologics, how does really understanding this full picture change the way we, as healthcare professionals, should approach a patient who comes in with what might initially seem like just a skin problem?
Something to definitely reflect on. It requires a much broader perspective.
Indeed. Well, that wraps up our deep dive into chronic plaque psoriasis. Hopefully that's been a useful, high-yield overview for your revision.
Breaking it down section by section like this, hitting the key associations and management steps, should really help consolidate the knowledge.
For more free MSRA revision resources, you can visit freemsra.com.
And for the full premium revision toolkit, head over to pastthemsra.com.
Thanks for joining us for this deep dive.